Good afternoon, everyone, and thank you for joining the H.C. Wainwright 2021 Ophthalmology Conference. My name is Michael Brotherton, and I'm on the corporate access team at H.C. Wainwright. While we are virtual this year, we're confident we're going to be able to provide value to you with over 35 companies presenting at this conference, as well as via your interactions through one-on-one meetings. H.C. Wainwright is a full-service investment bank dedicated to providing corporate finance, strategic advisory, and related services to public and private companies across multiple sectors and regions. We have a total of 19 publishing senior analysts and over 560 companies covered across all sectors. Please visit hcwco.com for more information. From a logistics standpoint, please make sure to reference your virtual conference online portal that provides your individual links to your meetings and all presentations. Please join us for panels that will be available live and streaming on August 17th. With that said, have a productive and enjoyable day. I'd like to introduce our first presenter. I'd like to welcome Brian Culley, CEO of Lineage Cell Therapeutics.
Hey, Michael, thanks very much for the introduction and the opportunity to participate in the first of what I hope will be an annual ophthalmology conference produced by H.C. Wainwright. And we certainly appreciate the research coverage that you guys provide on Lineage. Lineage being a public company, I refer everyone to our safe harbor clause, and you can learn more about our risk factors through our filings with the SEC.gov. So what Lineage is doing in ophthalmology is working to pioneer a new branch of medicine. And we describe it that way because what we are doing is we are manufacturing specific cell types and transplanting those cells into the body. So that's very different than traditional pharmaceutical approaches, which use small molecules or antibodies to try and change what's already there. We know that there's something broken in the eye in the condition of macular degeneration. And so we're trying to provide the replacement parts for what's broken. We do that by using pluripotent cells. These are cells which are undifferentiated. These are like high school kids that haven't declared their major when they go to college. They can become anything. They can become liver cells, spinal cord cells. Your body is comprised of over 200 different cell types. So one of those cell types are specialized retina cells called RPE, and we can manufacture those RPE cells in great numbers and then transplant them into the body. So just to be really clear about this, these are not cells that come from an individual with the disease. These are off the shelf. This is taking cells that are frozen down. They're manufactured in huge numbers, frozen down, and then they are administered to essentially any of the patients that they would be relevant for. And we do not manipulate the genome of these cells. We use a natural differentiation process to convert undifferentiated cells into specific types of retina cells. And by doing so, we avoid some of the hazards or the risks associated with some of the other approaches, particularly those associated with gene therapy. We are doing this clinically in 3 different areas. I'm only going to talk about OpRegen. OpRegen is our RPE cell therapy program, or we prefer to call it a cell transplant program, and it's to treat dry AMD with geographic atrophy. OpRegen is, as I described, an RPE cell transplant technology. We're treating dry AMD. It is one of the leading causes of vision loss in the world, but yet there is nothing approved for the condition. These panels, these 6 panels here, are images of the back of someone's eye, a person who has dry AMD. And you can see going from left to right, from 2012 to 2019, that black central spot, that is an area of atrophy. That is an area where retina cells have died off. And you can see that it is growing. It's getting larger. It's like a blister. You can think of it like a tumor or a skin cancer growing. It's roughly circular. And the hallmark here in this disease is that as these cells die off, it kills this area of the retina, which makes it dysfunctional. And you eventually lose your central vision, and you can become legally blind very rapidly. This particular person, we've graphed their vision in red. They've gone from 20/20 to legally blind in just 3 years, and then it only got worse from there. So this is what we are trying to treat. This is an enormous commercial opportunity. Macular degeneration as a whole comes in 2 parts, wet and dry. And we're very fortunate that the wet form of macular degeneration does have therapies available. Those therapies are doing about $10 billion in sales, but most people have the dry form and there's nothing approved. So there is a massive commercial opportunity, but it really does beg the question, why is there nothing approved? How have we managed to find therapies for wet AMD but not dry AMD? And we believe the answer in part is because no one really knows what's gone wrong in the setting of dry AMD. And if you don't know what's wrong, it's very hard to develop a tool to fix it. So our approach is indiscriminate about what's wrong. We don't care what pathway is broken in the cell. We replace the entire cell. There are a lot of different approaches. This is an image of all sorts of different companies or programs that are underway. There's gene therapy in here. There's complement inhibition, cell therapy in the top left. That's where we're focused. And to our knowledge, we are the company that has treated more patients with RPE cells than any other company in history. Here's how we do this. These two images here on the left, this is pre-transplant. This is sort of a cartoonish depiction of what's going on in the retina. As those orange RPE cells die off, they accumulate waste that's shown there in yellow, and they fail to support the photoreceptors in blue. That's why you lose your vision. Then moving to the right, you can see that we've manufactured, illustrated in blue, these new RPE cells. We transplant them to the eye so that they can clear that waste, so that they can support those photoreceptors. Mechanistically, this is exactly what we're trying to accomplish. We do this through our own GMP facility. We don't throw this over the wall to another manufacturer. That's because manufacturing cells is extremely difficult. However, we've had tremendous success. A lot of the know-how has been patented that we have developed. And at our current status, we actually can manufacture 2,500 clinical doses in just a little 3-liter bioreactor. So you're basically talking about a jug of milk, and in that jug of milk, thousands of clinical courses. And the nice thing is you can run a bunch of these bioreactors in series or connect them in parallel, and you can scale up. And what we're manufacturing in these bioreactors are pure populations of RPE cells. They come from a cell line that was established over 20 years ago. It's a single cell line. Just one cell line produces billions and billions of RPE cells and will produce all of the cells that we would ever need, even commercially. We would never change our starting cell line. It works very well. We're very happy with it. We, as I said, do not make genetic modifications to the cells. And once we go through this differentiation process, we don't detect undifferentiated cells in our final material. So a lot of the concerns that people have about things like rejection or cells becoming tumorigenic and starting to multiply, we've not seen that. We've not seen a single case of rejection of our cells or growth of some sort of cyst or tumor. We've treated 24 patients, the longest of which have gone out more than 5 years. We've also developed a thaw and inject formulation. So again, these are cells that are coming right out of a frozen state. They are thawed and they are put into an injection chamber and into the patient. This entire procedure takes about 30 minutes, and we think it's going to be a one-time treatment. We think the durability of this could be a one-time treatment. Possibly you would need a booster after a few years, but compared to the competition, which is developing an injection in the eye every single month, we think there are some serious administration advantages which a one-time treatment can offer patients. So let's jump into the clinical data with our replace and restore approach. So first, structure. We have seen evidence of retinal restoration, and this is a point that I'm going to come back to because we are the only company to ever show evidence of retinal restoration. The reason why this is remarkable is that human beings are incapable of regrowing retinal tissue. So every company out there is trying to show that they can slow the damage. We've actually been able to show that we could reverse it. We've also seen improvements in a reduction in drusen, which is that waste material. So structurally, we've seen some positive and encouraging changes. With respect to function, the majority of our patients are exhibiting improved or stable visual acuity. This is a big deal because this is a condition for which you only get worse. You lose vision over time. We have actually seen patients have increased vision. Again, almost everyone today is focused on trying to make these anatomical changes. We're having anatomical changes and functional changes. By the way, the untreated eyes, the majority of those untreated eyes got worse. We also have started to report out microperimetry data where we're measuring the actual areas where we've injected the cells and showing that there is greater visual detection of light in those areas. The safety and tolerability of this treatment has been quite encouraging. No unexpected adverse events or serious adverse events. And as I mentioned already, some of the long duration of this therapy going out more than 5 years. This is a snapshot of the 24 patients that have been enrolled on this clinical trial, the first 12 of whom were all legally blind. They had very advanced disease. We didn't expect to see very much. This was more of a safety component of the study. But in the second 12 patients, we were very excited because these are patients that had better starting vision. You could even drive a car in some cases with the vision that enrolled into this side of the study. I've highlighted here with green stars, there were 4 individuals who got a very thorough or complete administration of our cells, sort of the perfect administration. In 3 of those 4 cases, we saw retinal restoration. So this was very exciting to us. I'm going to show you an example of what this looks like. When you're looking at the back of the eye, when you're looking at the rear of the retina, you can use something called fundus autofluorescence to take a picture. It's just an aerial picture of that wound or that area of damage. And you can trace it and map it, and you can color it in. And we did that in orange. That is an area of damage in this individual's eye 1 year before treatment. Then we came back, and before we treated them, let's call it the day before they got treated, we took more pictures, and you could see that the area of atrophy got larger. It grew from orange to red. So this is an individual who has a confirmed growth of geographic atrophy, which everyone does. These things only get larger with time. Then we treated this patient, and 9 months later, we went back and we looked at the atrophy, and it's smaller. And that's the central panel. That's in blue. It's smaller than baseline, smaller than red. That was incredible. We could scarcely believe it. But I can tell you now that we need to update the slide. But I can show you there at month 23, the area of atrophy was still smaller. And now out beyond 33 months, it is actually the same size as it was at baseline. So that's quite remarkable, because no intervention has ever been able to show that it could stop the progression of this condition. So you have a confirmed atrophy getting larger, as it does in essentially every case in these patients. And this atrophy is the same size 3 years later than it was when we treated this patient. That is very exciting to us. This is a lot of bars and numbers, but it says the same thing. You can actually project where that patient should have been. Their area of atrophy should have been 4.58 square millimeters, but it was only 2.8 as it was immediately prior to treatment. So that was very exciting for us to see. No change in atrophy. And if you look at the historical record, all of these patients grow. If you look at anyone with atrophy over 33 months, they all get larger. So it's quite remarkable that this patient did not get any larger over time. I mentioned that you measure this using FAF, and that's an aerial picture. So here actually is that very same picture without it being colored in. That's what an area of atrophy looks like on the left. But what's kind of incredible here is that the way it works is that you're taking a picture of damaged cells. And so if you use our OpRegen cells, if you use our RPE cells and inject them into the patient, you can't actually see our cells. They don't autofluoresce. So we think it's much better to use a different kind of imaging called OCT, or optical coherence tomography. That is because OCT is the gold standard for imaging, and it gives you a cross section of the retina. So instead of an aerial view, you're really down in the ground looking at all 12 layers of the retina, and you can see them, and you can see exactly what's going on. Here's a close-up of what it looks like. Those of you who are familiar with the eye, this is no surprise, but a lot of people aren't aware. They think that the retina is just one layer of cells, but here's a dozen layers of cells, and all of them have a different function and role. And so if you're able to look at tissue that has degraded from this disease, and you can look at it after we treat it, and you can see that there is new nuclear layer, there's new external limiting membrane, there's new RPE, that's really incredible. And so we've been able to show this in 3 separate individuals, changes from baseline, that we've been able to reduce the size of their atrophy. Here, quite strikingly, is the difference between using FAF and OCT. FAF on the left, the difference between the orange and green line is the difference in growth rate of the patient's atrophy. So over the span of almost 3 years, you can see that the untreated eye in orange, it grew more rapidly than the treated eye. That's good. I mean, that's really nice. That is probably, I think most people would say that if you could do this, that this is an approvable agent. If you can reduce the growth of atrophy by about 30%, that's what some companies are going for. That's their hurdle. But look to the right. If you use OCT, if you drill down and really look beyond just this aerial view, and you get past the deficiency of being able to see our cells because they're not diseased and they don't autofluoresce, now you can see the true power of OpRegen and true power of cell transplant. 3 years, and that green line is below baseline. This patient has had a smaller area of atrophy for the last 3 years compared to the untreated eye where it continued to grow. That was the first patient. We've also seen small spots of atrophy called Aurora. That's incomplete areas of atrophy that have completely resolved. That's what's in this upper panel. The red arrow is pointing at an Aurora. And in the lower panel, you can see the tracing of the atrophy. Red at baseline and green is several months after treatment, is 2 months rather after treatment. So you're seeing repair of the RPE. You're seeing continuous ELM. And this has been verified by multiple retinal imaging experts. So this was the second case of retinal restoration that we reported, which included the resolution of Aurora, or these early incomplete areas of atrophy. Third case of retinal restoration. I mean, you start saying, well, how many does it take before you believe it? I believed it at 1, but now we have 3. So you can again see, going from left to right, the blue area at baseline to the blue area at 3 months, clearly a smaller area of atrophy. One of the auroras is totally gone, the red one. The yellow one has gotten much smaller. This is essentially healing of this area of atrophy, which again, no other company and no other intervention has ever shown. How is the patient's vision? Well, here you have now an inversion of the lines because we're now looking at visual acuity. So green is higher than orange, which is exactly what you want. This is a measure of letters that are read on an eye chart, just like if you're at the DMV reading letters. You can see that this patient now out at 36 months, the green line has finally fallen below baseline. That treated eye is now -4 letters, but the untreated eye is -40 letters. So there's been a very nice separation between the treated eye and the untreated eye. And I'm sure you're wondering about those first few months. We don't really expect very much to happen in the first few months, but I want to tell you that there was a follow-up surgical intervention. So this patient had a small ELM, an ERM that was surgically removed. That was performed at the 2nd month. So you can see that dip in their vision because they had a second intervention. That membrane was removed from their eye, and their vision boosted right back up to where it was, +9 letters, and remained there. So that was a very nice example that you can have patients that may develop epiretinal membranes, and you can remove them if they need to be removed, and you can still have a very strong clinical outcome in terms of vision as well as anatomy. This is not the only patient that's had a benefit in vision. Here are all of the cohort 4 patients. So these are all of those patients that have better starting vision. The green line is a measure of their visual acuity. It starts giving you another 2 or 3 letters in the first few months. Then it starts stretching out to 6, 7, 8 letters as you go on. And this now we have 12 patients at 6 months. And very soon in this quarter, we will be updating this and looking at month 9 with all 12 patients. So we look forward to being able to update these data with respect to visual acuity. This is important because it is tying the whole mechanism together. We're seeing anatomical changes and we are seeing functional changes. Again, no other company that we know of has been able to show the dyad of anatomy tied to function. Furthermore, we've also been reporting our interim patient-reported outcome data. So these are patients using a standard ophthalmology questionnaire and showing improvement in a lot of different areas with respect to pain and vision and so forth. It's just very pleasing to us that it's all hanging together, right? The prototypical patient for us would be someone who says, I'm feeling better about things. I feel like I'm seeing things. I'm testing better in my vision. And their physician says, and yes, your area of atrophy is also smaller. If that all hangs together, it gets increasingly easy to believe that the therapy that we are providing is driving these changes. So let's review, how are we trying to set up OpRegen for commercial success, and in particular address a multi-billion-dollar opportunity? Well, firstly, transplanting RPE cells might provide benefits that other approaches can't. No other intervention has been able to show that they can restore areas of retina or halt growth of atrophy. Our market opportunity, we do not believe, will be limited to monogenic deficiencies. So gene therapy requires you to fix a broken gene. We don't care. It doesn't matter what's wrong with these cells. So we don't have to segment the market. An analogy I use all the time is that if you get into a car because you need to go somewhere and the car does not start, you don't have time to test to see if it's the battery. Did you put in the wrong key? Is there fuel in the tank? We just give you a new car, right? So we don't care what's wrong with the cells. We give you new cells. We are the only company to show retinal restoration. This treatment has been well tolerated, 0 cases of rejection, no serious adverse events, and we avoid the risks that are associated with genetic manipulation. There is the potential for recurring revenues if multiple treatments were to occur years apart, although we are hopeful that this would be a one and done kind of situation, because we do think that these cells are going to essentially outlive the people who receive them. But we are far advantaged with respect to not requiring a monthly injection. Getting someone who has terrible vision to get to a clinic every single month for an injection in their eye when they could have a one-time 30-minute surgical intervention and be done for the rest of their lives, I think that's a pretty significant advantage. We may have an application in other retinal diseases. We treated a patient with vitelliform maculopathy. I would like to go into Stargardt's disease. There may be other retinal areas where we could provide a benefit. The company has many hundreds of issued and pending patent applications in various aspects of cell therapy, including covering aspects of our production, characterization, and formulation. We have fast track designation from the FDA. And the most important point is that the competition is trying to slow a degenerative process. We have been able to reverse it. So I invite people to consider the implications in terms of the strength or the power and the need to show statistical proof that you can intervene beneficially in these patients. Well, if you're showing that you can stop a progression instead of just slow it down, that is hard to miss clinically. So taking away from an investor perspective, Lineage is transplanting off-the-shelf therapies to treat serious medical conditions. Our unique advantage is that we can manufacture an unlimited supply of these self-renewing cells, all of discrete types. Our OpRegen program has completed enrollment in a phase 1/2 study in dry AMD with GA. We also have a spinal cord injury program where we manufacture spinal cord cells. That's been treated in 25 people. And we have an oncology program where we transplant dendritic cells, and that's in a non-small cell lung cancer program. Each of these programs has reflected some sort of differentiated and exceptionally compelling clinical data, whether it's tissue restoration or restoration of locomotion or induction of immune responses. Each of these, we believe, represents $1 billion plus commercial opportunity, and the company has a very good financial position. We just reported recently $68.7 million in cash and cash equivalents as of the middle of 2021, and the market capitalization obviously has room to improve as our story is shared, appreciated, and continues to evolve. So my takeaway for you on Lineage Cell Therapeutics is this is a company, it is a leading cell transplant company with 3 clinical stage programs with many opportunities to grow or partner. We control our own future with respect to our manufacturing. We have one of the largest patent estates in cell therapy. We enter into strategic alliances and we provide access to some of those patents for non-core areas that we aren't developing. We have a very cost-efficient business model, and we are an emerging leader in the field of regenerative medicine. And I sometimes say that there are new companies out there in regenerative medicine. Some of them are even more valuable by market cap than Lineage. They have not even encountered problems that we've already solved. We've been doing this for 20 plus years. If this is a story that is interesting to you, I encourage you not to just take my word for it, but take a look at some of the patient testimonials that we have provided. Both Sherry and Sonia are individuals whose data I shared with you today. Some of the images came from their eyes, but you should hear in their words their experiences being on this trial. And again, you're not going to find these videos from the competition, because slowing the growth of GA is not something that an individual feels. What an individual feels and cares about is being able to read the card from their child, being able to see them on FaceTime, and being able to engage with the world around them through the eyes that they have. And we're trying to make that an increasingly tolerable and positive experience. Thank you so much, Michael, for the opportunity to present today. I hope you enjoyed it, and folks can always interact and follow up with Lineage Cell Therapeutics, LCTX, anytime they want. We're very approachable and available. Thank you.
Thank you, Brian. I want to thank all of our presenters for taking part in what has been a very productive and informative series of presentations. We appreciate the time and effort that went into preparing them. Hopefully our next conference will be one that we could hold in person rather than virtually. But in the meantime, we're very grateful for your flexibility and your presence online. Thank you again from the H.C. Wainwright team.